First of all, I want to welcome everybody here to Carroll Hospital Center, our beautiful place. And I also want to recognize my friends from Frederick. So if you could raise your hand, I know Heather and Jenny and everybody here. So we're very glad to have you with us. And most of what I'm going to be talking about and my friends over here are going to be talking about, everybody's working on. So we just want to acknowledge them as well. And members of our Access to Healthcare team, and raise your hands, and our partnership board, if anybody's here, please raise your hands. You guys have heard me talk about this a bunch, and I'm sure everything that Donna was saying is pretty familiar to you guys. We've talked about the costs of the healthcare system, so we're going to kind of talk about what the hospital, the partnership, and the health department are doing together to help reduce healthcare costs in Maryland. So I want to start off by talking about population health. And it's our philosophy that we have three, I like to talk about it as three groups of people. We have people who are well, we have people who are at risk for chronic disease, maybe they have a family history or such, and we have people who actually have chronic disease. So we really need to, historically, we focused on the sick people up here in hospitals. We've talked to, the patient will go see their physician, the physician will say, oh, you need to go to the hospital, you're very sick. We're going to send you to the hospital and they will take care of you. And that's how it worked. So we focused a lot of our time taking care of people who were sick. Not a whole lot of time on people who were well because, they were well. So they're going to stay well and we don't have to worry about them. Or people that had risk factors, such as high A1Cs or high blood sugars for diabetes and stuff. We really said, they're managing it at home, so, they're doing a good job with that. Come see us when your blood sugar is really high and we'll take care of you. So we've learned that we really need to put programs in place to keep the well people well, and to really educate and help those people who are at high risk for chronic disease to know about that disease, understand that disease, so that they don't become ill with that disease and require further expensive hospital care. And we've learned that those people who have chronic disease, they can become engaged and they can become better managers of their chronic disease. So it's our job as healthcare providers here in this community to teach them to manage that chronic disease. So some of the ways we try to do that is we try to integrate care in the community. So we look at how can we deliver seamless care across multiple systems. It's very complex. We have primary care and specialty offices, we have ambulatory centers, clinics, acute care facilities such as hospitals, community resources out there, we have health departments, we have clinics, all kinds of other programs going on, and oh, by the way, we have long-term care and rehab centers that we have to think about too. We want to develop programs to assure the use of the most appropriate care setting at the right time, and as we heard Donna say, at the right cost. It's very costly, so we want to make sure we're caring for people in the right place. Could the patient benefit from going to the doctor, from having some home care, come and see them, versus having to come to the hospital and receive that more expensive care? And we want to make better use of patient information to support the caregiving process. One of the things that we've really had success here, one of the frustrations is being able to share data. And I think every hospital and Jenny shaking her head, every hospital and every organization is frustrated with the fact that if the patient comes to the hospital, their physician doesn't always know it. Or if they're in a long-term care facility, they don't have access to the care that the patient received while they were in the hospital. So one thing we really are working towards here in the state is trying to come up with a way we can better share healthcare information. So I'm really looking forward to the day when I can pick up the phone, or if I call and I need something, my physician can say, oh, I see you were at the hospital, and I see that you were placed on this prescription, and you got it filled here, and how can I help you manage that? So we're looking forward to the day when that happens. We've had a lot of success here. They're trying to do some work with putting people on care plans and navigating them. We had a pilot that we tried between several of our physician and primary care practices, our emergency department, and our care navigation team. And we really worked to look at how can we stop the excessive utilization of our emergency department. Huge problem here. Most places throughout the United States, they count how many people come into the hospital 3 or more times a year. We count how many people come into our hospital 3 or more times a month, okay? It's a real problem, and I'm sure others have the same issue. We looked at all the patients that came in the hospital 3 or more times a month, and we were running anywhere from 7.2 to 7.5% of the patients that were coming into our emergency department were coming in 3 or more times a month. Through doing care plans and just simply how we talk to these people, looking at what some of their social determinants were, look at what some of their issues were, we were able to reduce that from 7.2% down to 5.4% over the last year and a half, just by creating care plans and working with their physician and creating that system of care for those people and getting them connected in the community. Lots of good stuff going on there. What we'd like to do now is take those processes and move them to our bigger things, such as diabetes, high cholesterol, and high blood pressure that Donna was talking about. How can we work within our newly formed ACOs to do that? Accountable care organizations, for those of you who don't know what that is, it's where physicians and communities and hospitals partner to better care for the patients. Some key initiatives that we have going on here at Carroll, and I know Heather also at Frederick. Lots of partnering with our long-term care facilities. Lots of stuff there related to end-of-life and palliative care we've learned, but also how can we get good physician coverage. We're learning that a lot of our long-term care facilities, they have physician coverage, but when they call the physician and the patient's having a problem, what do they tell them to do? Go to the ER, okay? We hear that all the time. So we're trying to figure out how can we create systems of care in those long-term care facilities to prevent that go to the ER and better care for them in the facilities. We're increasing our focus on palliative care and hospice. We did a little study here, and we realized that only about a quarter of our people who could have benefited from palliative care actually got palliative care. So we're really trying to do a community focus to better enhance palliative care in our community and kind of change the name of it, because we also find a lot of people equate palliative care with hospice. So they think palliative care is end-of-life care. So we're trying to figure out how we can better market palliative care to people. Better identification of our high-risk patients. Who are they? Where do they come from? What do they need? Putting all kinds of systems in place to be able to do that. Improving patient engagement and self-management. We want to get patients engaged with their own care. We want them to be able to take care of themselves. The people that come in and think, you know, if you give me a pill, I'll be better. There's more to it than that. So we have to really teach them about their chronic illness and how to manage that. Improving discharge processes. One of the big things we're working on here is how can we better make sure that the person is successful when they leave the hospital and go back to the community? What kind of things can we do to make sure that they don't come back to the hospital to receive that care? We have everybody who on the Access Carroll team knows what, or Access to Healthcare team knows what a readmission is. Everybody knows what okay. We're all talking about readmissions. How can we keep people, if they do have to come to the hospital, we want to keep them out of the hospital, but if they do have to come to the hospital, how can we make sure that their care is such that they don't have to come back and connect them with those resources that they need? Improve patient callbacks. One of the things that we've learned, Robert, did I see you here on my executive? Did he leave? Okay, we had some of our executive team here. Robert shared with us last week that just by improving the patient callback process when a patient leaves the hospital, we can improve their chances of not coming back to the hospital by almost 80%. So that's good patient follow-up, making sure that if they're having problems at home that we're doing something about that. That's important stuff. Healthcare collaboration, home health collaboration. You heard me say a lot of what's going on in home health and in long-term care facilities is what was happening in the hospital years ago. So, our home health agencies are where it's at, and the nurses and the staff working at these home health agencies, they need to be trained and they need to look at their processes and how we can better care for the patients in their home and keep them from having to come to the hospital. What kind of process can we improve there? Disease management and follow-up care, I've already talked about that. What we're really going to focus on in this presentation is how we can work with community agencies and groups to improve access to care and engagement. You know, hospitals can't do this alone. We need the community to work with us and help us, and we've realized that here, and we want to share how we're looking to do that and how we are doing that. And Care Connect is a program we have, I'm sure, I don't know what you call yours, Heather, but the care navigation and care coordination process. Care transitions, right. So how can we improve care coordination and patient access in the community? Okay. So broader, what we're looking to do is have physicians align with patients through our accountable care organizations and our physician hospital organizations. Hospitals need to partner with communities. We're doing a lot of work here in our community. Looking at a system where there's constant contact with caregivers and 24/7 availability to necessary programs. A lot of what we find is that our programs are 8 to 4 Monday through Friday, and my health department people get tired of hearing me say this, but 8 to 4 Monday through Friday. What are we going to do on Friday night at 10 o'clock when the person comes in the hospital and they need help? What are we going to do? We end up admitting them to the hospital. If we could have programs, and I'm going to tell you a little bit of success with our behavioral health program, if we could have programs that are accessible to people after hours, we can improve that. Tighter monitoring of utilization of expensive healthcare services. My case management team, they're constantly doing this stuff. Guaranteed same-day sick visits. How can we get people into urgent care or to their primary care versus coming to the ER when they're sick? Our primary care providers are seeing lots of patients, so we want them to be able to see you when you're sick as well. We want to try to work with them on how we can do that. Free educational classes, hotspotting chronic disease within communities. Where do we need to go to provide the services? We're looking at taking a lot of our outpatient education services on the road, some up in Tawnytown. You know, what can we do to go up there and see the people up there because they can't get here to us? Let's go to them. Community education programs, better access to those programs, and active engagement with care navigators and care coordination. We talked about that. So, how are we going to do this? How are we going to identify this? We want to develop systems of referral. How do we get community members to the proper referral systems? And are they enough? Is more needed? We ask ourselves that question all the time. We identify our health risk population. Dot's going to talk to you a little bit about our community needs assessment. But when the partnership does our community needs assessment, we look at what are our areas of need and how can we strategize around those areas of need to provide the services necessary in our community to do that? So our strategic plan for the hospital surrounds the community needs assessment. Our community benefit plan surrounds the community needs assessment. We sit down with members of our community, our health department, and other interested groups to prioritize what we're going to do in our community to make a difference. So I think that's something that's kind of unique here in Carroll that we've been able to successfully do. We identify our high-risk populations in area of need. The last 3 years we've been focused on behavioral health, diabetes, stroke, heart disease, and chronic obstructive pulmonary disease in the known as relates to smoking and all those other issues. And what are the needs of this population? We've learned that it's not just healthcare. We've learned that they need greater access to affordable primary care. We've learned that they need transportation. Transportation's been an issue in our community and we need to work on that. They need affordable medications. We discharge people from the emergency room in the hospital with prescriptions. How do we know they got them filled? How do we know they can afford them? We need to address that. And many other needs that are being identified by both our navigators and others in the community. And I'll tell a story. Kevin talked about our stories. You know, one of our patients we had with asthma, her and her daughter were coming to our hospital. They were one of our ER high utilizers. They were coming 3 or more times a month. We looked and looked and looked and what in the world is going on with them? Why do they keep coming to the emergency room? We found out that they didn't have a good heating system in their home. We found out they were using a wood-burning stove, which was exacerbating their asthma. So we were able to connect them up with some resources to be able to get an affordable heat pump or get their heat pump working for their home so that they could not have to use their wood-burning stove to heat their house. And guess what? They stopped coming to the ER. So it's not just providing care for people, it's looking at the other things that are going on in their life, their social determinants of health. What can we do to provide these things to keep them healthy? Okay, so that's a big part of what we're doing. So just briefly, I want to talk about our behavioral health outpatient health clinic model. My behavioral health people, Sue Doyle, raise your hand. Sue Doyle, I'm talking to you. So that team has been phenomenal in working together. You know, we said that behavioral health was a huge issue. So we're looking at what our objectives were, and you know, I'll have this available to you. But really, we wanted to create systems of care where people could come together to work on the problem of people accessing our emergency department, our behavioral health services. Looking at the most appropriate setting, this is our inpatient average daily census. We went from about 16 down to between 10 and 12 patients admitted on average to our behavioral health unit. Through creating initiatives such as pain management, I talked about our Care Connect, Health Navigators, SBIRT, which is symptom, tell me what it is. Screening, brief intervention, and referral to treatment. Got it. Yay! Care plans and peer support specialists. We also were able to decrease the number of evaluations we saw in our emergency department and the number of patients admitted from our emergency department significantly by putting all of these programs together. It's oversight by the Behavioral Health Advisory Council, which I want to just establish that when I say it contains necessary stakeholders, it's not just healthcare people. We had law enforcement, we had people from the community, we had religious groups, we had all kinds of people that participated on these groups to work on these programs to decrease these numbers. So what my point is with going over this example is that we really are including everyone, not just the healthcare providers in the community to get these results. Right. And one of the other things is this work group is a function of the Partnership for a Healthier Carroll County, which I'm going to just let Dot talk, because I've talked enough. I'm done. I could talk all day. Anyway, I want to introduce Dot and let her talk a little bit about our partnership and how we make all that happen.
The partnership is an extremely innovative organization that I am proud to be part of. Our tagline is connecting people, inspiring action, and strengthening community, and I think that sums up very nicely what we do. We do not provide a direct service. We do not provide a product. Our mission is really to build the capacity of individuals and organizations to improve the health and quality of life in Carroll County. And we are able to accomplish and meet the needs of today. And we do this through assessing, tracking, interpreting health data in our community. At the present time, we are conducting the 2015 Community Health Needs Assessment with Carroll Hospital Center, Carroll County Health Department, and even more importantly, the community as our partners. As you can see here, each organization is able to use the results for future planning purposes. And although the uses may be slightly different, we're still all working from the same data collection, the prioritization, and process. So that we're working from the same page. We're all working from that same page. This loop process chart shows how the needs assessment, the prioritization process, and the data really drives our work. It'll do this through integrating the implementation strategies into the hospital strategic plan, the partnership strategic plan, and the health department strategic plan, through the community benefit and health improvement plan, and through responsibilities and accountabilities. And in turn, this will drive the service lines for Carroll Hospital Center. It'll drive the partnerships leadership teams. It'll drive the physician hospital organizations and the accountable care organization, as well as our local health improvement coalition. And all this will be completed with the objective of impacting our community's identified needs. And as for the results, we use Healthy Carroll vital signs as our results accountability, our measurement of the progress in each one of our identified areas. And we do this by influencing change. And I think with that, I'm going to turn it over to Barb to say how this all comes together. Okay, great.
See, Benny, we promised we'd be short and sweet.
Yeah. He gave us a comment.
What she needs to do for people like me. But anyway, basically my job today is to sum this all up for you. And if you have any takeaway message today, this is the takeaway message that you need. This is the model, more or less, that since, I guess the partnership was even thought of and the collaboration between the hospital and the health department back in the late 80s, this is where we've come. And this is absolutely phenomenal in my mind, because we're really, believe it or not, back in the 80s when I first started at the health department, the hospital and the health department did not talk to each other. And just the fact that we are here and standing in this wonderful facility and it's all about wellness, I think I can retire now, Henry. But anyway, you're in charge. But this basically shows you what we've done is that the hospital, the health department, the partnership, we've all come together with the aspects that the health department needs to accomplish on our side and what the hospital needs to accomplish, and we brought it all together. And we now all get together, we do the same thing, we don't duplicate community health needs assessments, we don't duplicate collection of the data. I'm so glad I don't have to do as much secondary data collection as I used to. Because when I first came to the health department, I thought I was the epidemiologist, not the health educator. But I learned how to do a lot of that too. So I'm thankful for all of HCI and all the great databases out there that do that now. But what I want to just focus on real quickly is where we've gone just most recently. And while the partnership has been in charge of health in the community, with a lot of things that have been going on with the waiver, with the all-payer system, with what we were looking at potentially doing with the state innovation models, we basically in Carroll County had to take a little bit closer look at actual health care. So we formed a population health governance group. Believe it or not, it's been a year ago since we did this. And some of you on the Local Health Improvement Coalition know that we needed to do this and that we needed to focus on it. And these are some of the things that, of course, most of you know what a Local Health Improvement Coalition does. But as part of our partnership board and them also being our Local Health Improvement Coalition, which we thought was very innovative because we did not go out and reinvent the wheel here. We created a group of people who've been with us, some of them, Jerry, since the late 80s, mid-80s with me. And I know Art Riley's not here, he would be another one. Some of us have been around, when we were thinking this back in the 80s. So we just kind of tweaked it a little bit for us. Now called the Local Health Improvement Coalition, and we're moving forward greatly. But what we needed to change was we did need to create a group that consists of members of our LHIC and community members and others who are not on the LHIC that we specifically need for a specific purpose, and created what we call the Population Health Governance Group. This is not an actual full-fledged subcommittee of the partnership. It's not in our bylaws. That may have to be looked at. But basically at this point we do have a group that gets together and talks about how are we going to do all these things in Carroll County to have these better outcomes for our residents. So it's clearly taking what we had this big, originally it's funny because when the partnership started we were like, this cannot be just about healthcare, and now I kind of jokingly a little bit was mentioning to Donna that I feel a little bit like for myself it has come full circle, because when I started this it was all about to the hospital, it was all about you can't focus on just health care, and now we've done health for so many years and now we're back to let's look at the health care. So this group, and that's only because I've been here forever, but so this group has really come together. We've really already done some great things. We're going to continue to do some great things. And if anyone's interested in being on this group, certainly the invitation is open, the more the merrier, but all with the purpose of making Carroll County a healthier place to be and live. So I think I'm done, Vinny. So
thank you very much.
And there are members at the moment.
That was great. Thank you very much to Barb, Sharon, and Dot. Let's have a big hand for all three of them. You and Carroll County are doing